Hi everybody, Ziv Simon here. I'm the creator of SurgicalMaster, the surgical training for dentists. Welcome to another video. And this time I'm going to talk about the free gingival graft, also known as the FGG. And the idea behind this video is from a dentist practicing in Yemen, Dr. Alatami, who sent me an email with some questions about the free gingival graft and how I use it to treat recession of lower incisor teeth. So, Dr. Alatami, this video is for you. Thank you so much for your email and questions and being part of the SurgicalMaster community globally. I hope you find this video very useful. Now, when we talk about soft tissue grafting techniques, it can get very confusing because there are so many out there and there are so many different variations on the same procedure and also different ways to treat the same problem. But really, there are only two types. We have free grafts, which are basically grafts taken from one place and transplanted. It could be the patient's own palate. It could be a tissue bank. And we have pedicle grafts, which are a type of tissue manipulation where we move a flap, let's say coronally, to cover recession. Now, free grafts could be submerged under a flap, and they could be left exposed, non-submerged, depending on the indication, depending on the procedure. Pedicle grafts can be rotational, can be moved laterally, sideways, or can be moved coronally, advanced. And very often we use a combination of the two, combination of free grafts and pedicle grafts, which is, depending on the case, is something that is quite common. Now, the free gingival graft falls under the category, obviously, of free grafts, because it's taken from the patient's own palate. And it's a non-submerged graft. It's left exposed. Now, another name for it is the epithelialized palatal graft, because we're harvesting a piece of tissue that has mostly epithelium and some of the connective tissue from the patient's palate. And once we transplant it, it still carries the genetic information to form attached and keratinized tissue, because that's how the palate is. So I wanted to show you some of the main indications for this procedure, which is usually low incisor teeth. I'd like to say 90-95% of my free gingival grafts are in this area. And typically, these are relatively young patients with recession, with poor tissue quality, no attached or no keratinized tissue, and sometimes also a free and pull. And they really work great in this area. So I'm going to describe the surgical technique, but before we go over the procedure, we need to determine some goals. So the main goal of a free gingival graft is to improve the tissue quality, improve the zone of attached and keratinized tissue. Now, once you do it, you will prevent more recession in the future, which is the second goal. Now, sometimes we can also get some root coverage, but don't promise this to the patient. There are better ways to cover roots. So I'm going to show you how this works. So the first thing that you need to do, be able to do, is to identify the mucogingival junction. This is where your first incision is made. The first incision is a split thickness incision with a number 15 blade. And the extent of it, mesiodistally, depends on the area that you'd like to treat, depends on how many teeth, but also depends on the size of the graft that you'd like to harvest. We are limited, obviously, in the palate. So now in the cross section, you will see that the incision is a split thickness, and basically you will start reflecting a split thickness flap or a partial thickness flap. And once you do so, you will see something that looks like I call it a smiley face, and the underlying connective tissue and some of the vascularity will be exposed. Now, be careful not to create a pouch. That's one of the main mistakes the doctors are doing. Trying to do a free gingival graft, they're creating a pouch, and then the graft is placed underneath the flap, which is a mistake. This type of flap design is very superficial. You don't have to go into the depth of the tissue. You need the tissue to open up, expose what's underlying. And what you do next, you stabilize this flap with interrupted sutures, ideally gut sutures, and keep it open. Now, if you have some attaching keratinized tissue to some extent, what you'd like to do is deepithelialize it. Take a new number 15 blade or a micro blade and remove the superficial layer What this does, it creates a better blend for the graft, increases the vascularity from underneath. So once you have the flap ready to receive a graft, you will go to the palate and harvest the free gingival graft the size that you plant, depending on the recipient site. This graft is going to be of a thickness of about 1.5 millimeters. And if you're just starting out, I recommend you harvest a rectangular shape. The area to harvest from is the palatal aspect of the premolars and the molars. We're going to stay away from the rugae and stay away from the soft palate that actually has no attached tissue, and we don't have to go there. It's defeating the purpose and also risky. So this is the zone. We'll also stay away from the free gingival margin, not to create recession. So we're looking at about a minimum of 2, maybe 3 millimeters away from the margin. So once you harvest your graft, you'll place it on ideally a moist and cold gauze. You'll adjust it. Usually we take off the corners to match the recipient site. If you have some type of tissue tags, or maybe you have some glandular or adipose tissue on the profound part of the graft, you can very carefully remove it, handle it with extreme care, and bring it to the recipient site, where you'll suture it only at the coronal aspect. So the sutures that are stabilizing the graft are only at the coronal aspect, through the graft and through the attached tissue. Don't suture apically, because remember, the apical tissue can move, is mobile, and that can create some graft stability. A lot of finger pressure. Sometimes you use something called a product called periacryl, which is medical grade cyanoacrylate for some stability, and that's basically the technique. So when we see common indications for a free gingival graft, you'll see the recession, you'll see many times inflammation, no attached, no keratinized tissue, you'll see often a frenum pull, and if you place a probe on the buccal, you'll many times go through the attachment and probe into the mucosa, and that tells you that there's no attached or keratinized tissue. So these are great indications. What doctors are having most trouble with is the flap preparation. So again, just to repeat, this is a split thickness flap that opens up and gets stabilized apically, and the residual attached tissue gets de-epithelialized by very carefully removing the superficial layer of epithelium, and that increases the vascularity and improves the blending of the graft throughout the healing period. Again, going to the palate, the harvest is in a rectangular shape, ideally. The thickness of the graft would be 1.5 millimeters, and you very carefully start from one corner, carefully dissect this graft out. Once you remove it, there'll be some bleeding. You'll use some pressure, local anesthetic, and maybe some type of hemostatic agent to control the bleeding. Then you'll place it on a cold and moist gauze. You can irrigate with some cold saline and bring it to the recipient site and suture the graft, mostly the coronal aspect, maybe sometimes laterally to the side. A lot of finger pressure. And basically, this is the end of the procedure. This is how the graft is sutured. Now, you'd like to give the patient some very careful instructions, what to do, what not to do at home. So I tell patients, don't brush the area for a few days. Then I provide them with a very soft brush. They can only brush their teeth, not get close to the gingiva at all. No flossing, no rinsing. And basically what you'll see a week later, you'll see that the epithelial layer is sloughing off. That's not a problem. That's part of the healing process. What's important to see is the red and vascular tissue from underneath. And if you can, leave the sutures in perhaps for one more week, a total of 2 weeks. After 2 weeks, you'll take out the sutures, and then the graft itself will start to epithelialize, to keratinize again. And it'll take probably around 4 to 6 weeks for the graft to start blending in and achieving your result, basically getting more attached, more keratinized tissue, preventing further recession, and in this case also was able to get some root coverage. And naturally, as you do the graft, just by definition, you're eliminating the Freenham pool. The reason this graft works so great, and I have to say the success rates are in the high 90s, is that the graft itself is placed on a very vascular area. And initially, it's getting its vascularity through the plasma, through plasmatic circulation. No actual vascularity into the graft, but it stays alive just through the plasma. Eventually, it gets revascularized through the surrounding tissue, and at some point it'll form its own tissue. And I can tell you again, this graft works extremely well. It's a very predictable type of procedure. Now, to do this properly, you'll need to use two critical products. One of them being a hemostatic agent for the palate, an astringent, for example. And the palate is going to be the source of patient discomfort and bleeding and problems throughout the healing period. That's part of this procedure. So I use the hemostatic agent to control the bleeding, in addition to local anesthesia and definitely a lot of pressure, definitely 5 to 10 minutes of pressure at the end of the procedure. The other critical product is using medical grade cyanoacrylate. The product name is periacryl. I use a couple of drops just at the edges of the flap, and that increases the stability tremendously. Now, just be careful. All of the doctors that are using it get so excited they start placing a lot of it on the graft and on the lip. Don't forget, this is cyanoacrylate, basically super glue, and you may see the lip sticking to the graft, which you don't want. So be very careful when you use periacryl. Another very interesting phenomenon that we see with free gingival graft is called the creeping attachment. And that's a phenomenon that we see up to 1 year after a graft is being done. We see the tissue creeping about 1 millimeter. So don't get discouraged if you didn't get root coverage right away, and tell this to the patient. Wait 1 year, you will see some tissue migration, basically because the sulcus is forming, and we see some improvement over time. So when you consider patients for a free gingival graft, first of all, determine your goal. If your goal is to improve the tissue quality, prevent further recession, this is an excellent graft to perform, and it's an excellent service for the patient. For root coverage, it's not the best, and for this patient, for example, has very poor tissue quality. If you're going to try and manipulate this tissue and split it, or use a tunnel technique or anything else, you likely will tear the tissue and create problems. So I recommended a free gingival graft to improve the tissue quality and prevent further recession. And was a little bit disappointed initially to see that there was actually no root coverage at all, good tissue quality, but no root coverage. And about 1 year later, you see the tissue starts to migrate. And my opinion is that once the tissue is stable and keratinized, it has the ability to form the sulcus properly and cover some of the roots. So it was definitely a success on all three goals. Better tissue quality. We definitely have almost a guarantee this will never recede again. And we also got some degree of root coverage. So give your grafts a chance. So the free gingival graft is an excellent technique to apply and service patients. It's been around for a long time, since 1962. If you get really good at it, in future courses and training programs, I'm going to show you how to use free gingival grafts to improve implant sites that have very poor tissue quality, minimal attachment, and we know this is a problem for implants. And I'll show you how we use a very similar technique. We improve the attached and keratinized tissue, and basically we get a better soft tissue profile around an implant. So that will come in the future, and I'll definitely show you how to do this step by step. So I hope this video was useful to you. Dr. Alatami back in Yemen. I hope you can now apply this procedure and help your patients with improving tissue quality, preventing more recession, maybe some root coverage. And if you like this video, feel free to share it with other dentists that may find it useful as well. And also visit me at surgicalmaster.com. Opt in to get my weekly blog and videos and other announcements on products and future training programs.